My name is Deborah Rigg, and I will be moderating this morning's session. This morning we have two of our expert wound care nurses who will be presenting to us. I'd like to introduce Mrs. Cynthia Timms. She has been a nurse since 1995. She earned her certification in wound ostomy in 1997 and has been a member of the Wound Ostomy Care Nursing Association for the past 27 years. She has worked for Emory Healthcare for 20 and a half years and now covers both inpatient and outpatient care communities at Winship at Emory Midtown. Her favorite things to do are being with family and friends, working in the yard, walking her two dogs, Finny and Stevie, and also spending time with her husband and traveling. Miss Marie Turner, she comes to us from the Emory Clinic Surgical Oncology Colorectal Group. She has a world of experience. She was in international shipping in 2006, and she later graduated with her nursing degree in 2008. It was during her second nursing class that the local wound care ostomy nurse came to give a talk, and Marie was hooked. A little under 2 years after graduating, she went through Emory's accredited wound ostomy care education program, where she becomes certified early 2010. She has worked both inpatient and outpatient, and as I mentioned before, now covers the Emory Clinic Surgical Oncology Colorectal Group. In her spare time, she enjoys pickleball, flower gardening, and traveling. I'd like to invite Miss Cynthia Timms to come forward first to begin our presentation.
Thank you, Deborah. Good morning. How are y'all doing? I'm a little nervous, but we're going to get through this, okay? So I'm here to talk about WOC nursing and the oncology patient. I'm actually just doing a case study about a patient that Katie and I have seen or have worked with over the past year, okay? So I have no disclosures to declare. All of my photos are an Emory patient, and permission to use the photos were obtained. In fact, the patient that I'm doing the presentation about, he asked me it was okay to do this if there was a lesson to be learned. So hopefully you'll see that there is a lesson here. Okay, so people need to pull out your telephones and sign into Evergreen. And the password for Evergreen is general, okay? So I'm just asking a couple of questions that I want you guys to answer after you're able to. Okay, so I'm glad that 64% said yes, because I'm the worst person to defer anything. So, but I'm learning from my patients not to defer any of my appointments or procedures. 33% no. Oh, I am impressed, and I need to learn more from you guys too. So your answers, and I really appreciate these answers. Work schedule, you're scared, may have a prior appointment, no time, life issues. Does anyone want to elaborate on their answer for me? Nobody. Okay, please elaborate.
Honestly, dental procedure came into my mind because they have you make 6 months in advance.
Right.
And I'm like, okay, this is great. And this answer or whatever. Then I forget about it. Then it gets closer to the time, and I have a million other things. I have work, I have my kids, I have whatever I'm working time probably, and then I end up, canceling it. Say, oh, I'll schedule later.
Right.
When you cancel, they'll say, would you like to reschedule that? Fall for you back. And then 4 more months goes by, and
Exactly. I do that too. Unfortunately, when I was in my 20s, I had a lot of health issues that I was in and out of, doctor's offices and hospitals a good bit. So later in age, once I got well, I, did not want to have those experiences anymore. But, I'm older and there are issues that come up. So not putting off appointments. I'm learning not to put off appointments because they're so important. But I'm moving forward. Just escape. So my case study is about a 57-year-old male, past medical history, basal cell cancer of the left side of his nose and ear. He did have a Mohs procedure to surgically remove the cancer from those areas. Now, basal cell carcinoma, it is a slow-growing cancer that, if not neglected, you shouldn't have to worry about it. Okay, it's not life-threatening. So moving forward, this happened 3 years ago when he had the Mohs procedure. About a year later, he actually felt a swollen lymph node in his left side of his neck. He didn't do anything about it. He just sort of watched it. And 3 months prior to his presentation at Emory, his girlfriend noticed it. And she encouraged him to go seek medical advice. So he did. He went and made an appointment with his primary care physician. Of course, it took a while for him to get in. But the physician, he referred him to a local dermatologist in Columbus, Georgia. He went to the dermatologist, and the dermatologist referred him to Emory. So he presented at Emory in October. They did imaging and biopsies, and imaging showed that he had a 3-centimeter mass on his mandible or his lower jaw. The biopsies showed that he had keratinizing squamous cell carcinoma of the left neck. Okay, so keratinizing is fast spreading cancer, unfortunately. So they decided to do surgery November 2023. He actually had his left parotid gland removed. He had a left neck dissection, which removed his lymph nodes. He had left mandible or partial mandible removed. They actually took the fibula along with soft tissue, a vein and an artery to reconstruct his face or his lower jaw. They took a skin graft from his right thigh and put it over his right lower leg wound, and also placed the wound back over the side as well, or negative pressure therapy. Excuse me. So his hospitalized was. There were no complications. He actually left 7 days. He was there from 11:15 through 11:22. His day of discharge, he was on a moist mince diet of oral supplements for wound healing. His recipient site flap was full, soft, warm to touch, and the sutures were intact. The donor site, his right fibula area, they removed the wound vac or the negative pressure therapy and applied xeriform gauze. And they recommended that xeriform gauze be applied daily, but to leave open to air 4 hours a day. He also left with the right lower leg stabilizing boot, which he needed to wear for 4 weeks. He was instructed to wear for 4 weeks. His post-op visit to the clinic, the first post-op visit, there were no complications, no issues. They said that the right lower leg graft site looked good, and there were no problems. His second visit was actually on 12/20/23. That was his first day of radiation treatment for him for his head and neck cancer. He did not have any chemotherapy, by the way. But on that day, the patient complained of malodor and pain to his right lower leg. That's when the wound care nurses were consulted. So my colleague, Katie, sees him first, and this is what she walks into the room and sees. On the left side of the screen, the wound is covered in this thick necrotic tissue, which she was able to do conservative sharp debridement to the wound bed using a scalpel and scissors. And the picture here is what she got down to. The tissue wasn't very healthy, of course, and so she recommended that the patient start a treatment using a hydrophilic cream covered with a foam dressing. The hydrophilic cream the ingredients are very simple. It's dimethicone, which is a moisturizer, petrolatum, and also zinc. But that combination is amazing for debriding wounds, along with a foam dressing. So the patient was instructed to apply this dressing every other day to either clean his wound with showering or with normal saline. He returns to the clinic in a week or 8 days, and this is what he comes back with. So the wound has been debrided using the hydrophilic cream and the foam. The wound bed is more pink. There is a exposed tendon, which Katie had to debride just a stringy tendon. But the wound had decreased by like 3 centimeters in just a week's time. It was probably also due to the amount of healing, also depended on the amount of swelling. Probably there's much less swelling in the leg as well. So, our subsequent visits, of course, I'm not showing you every visit, but he was having his radiation treatment on a regular basis daily, and we were able to see him weekly for a little while, and then we spread out the visits as we saw that his wound was progressing. But every time we saw him, we made tweaks in his wound care. We did use a hydrofiber at one point because he came in with a malodorous drainage, and the hydrofiber has silver in it, and it still did the same thing. It was moist wound healing. The silver was an antimicrobial dressing for him, and it worked very well for him. Everything that a wound care nurse does in wound care is based on moist wound healing. So we do not tell our patients to take off a dressing for 4 hours to let it air out. Okay, that isn't something that we learn in school, and we have seen our results over and over again, how well they work. This has been an 8-month progression, but as you see, last week I did see him, and his wound was almost healed. At this point, I actually told him to start wearing a Band-Aid over the site. So, psychosocial issues that he had to deal with. Physical, he had a lot of pain in that leg, but also he had a lot of pain everywhere. Just imagine having a surgical site on your face, on your thigh from the skin graft, and also your lower leg. He had lower extremity edema, so we recommended that he wear compression to help with wound healing. Okay, if you have a swollen leg and you have all this ointments and dressings available to you, it's not going to heal if you have a lot of edema. Okay, so adding compression to his care. Social relationships. His partner was pulled into having to deal with his healthcare issues right away. She was the one that encouraged him to go see a doctor, okay, instead of him taking the initiative. And how many people in this room somebody has told you to go see somebody or recommended you to go see somebody? Or instead of you taking the initiative? I mean, I know I have. Unfortunately, he told me he doesn't have any immediate family support. He said that he really appreciated when people would text him and just ask him how he was doing during his day. And a lot of those people were people that he sold products at a flea market. So he made friends with these people at a flea market that would call and check on him on a regular basis. So the practical concerns for him, he said that he had problems with communication with the healthcare, his healthcare staff. He said it was very difficult to call in to Emory to get an answer right away. But, he did learn how to use, I'm trying to think of the word, portal. Thank you very much. So his work was an issue because he had to take off from work for his radiation treatments. And, of course, that caused financial issues as well. He traveled from out of town to Emory, so just gas and parking costs was an issue. Wound care supply costs was another issue. Thank you. And medication costs. So to wrap this up, the patient was seen in the clinic by the WOC nurse services on a weekly, bi-weekly basis while he was having XRT. Conservative sharp debridement and silver nitrate to the wound edges were used on a regular basis. Dressings were modified as needed to balance moist wound healing. Ongoing education provided wound care regarding wound care, nutrition, and compression therapy. A financial navigator was involved in his care. She assisted with attaining charity care. In fact, he's on charity care now, so it was twice. And the social worker was able to provide parking passes, gas cards, and financial assistance for medication as needed. Okay. Last week when I saw him, he was back in the clinic, and unfortunately, he has other areas that he's going to have to be addressed. And he was told last week that he will start chemotherapy soon. So, thank you. Now I'm going to give it up to Marie. Okay?
Cynthia. Good morning, everybody. It is definitely the glamorous side of nursing, right? My patients are your patients. Your patients are my patients. I think that's the biggest take-home message for me and Cynthia. And patients tend to start with me, and I send them off thinking I'll never see them again, and then I see them back again. So getting in the Emory system, it truly is a collaborative effort from all of you. So I appreciate everyone's assistance in this room. I, like Cynthia, don't have any financial disclosures. All the photos I have except for one are indeed our patients, and I got permission to use the Emory patient photos. So a couple of objectives here that we'll go through, and I'm hoping I can answer each one of these as I go through the presentation. And as you know, I don't need to tell you this, our patients are not typical. The comorbidities, the age alone, they're compromised. If you have pain, if you have cancer, you're likely going to have some kind of pain, right? If it's pain from the wound not healing, neuropathic pain. If you have a limb that's swollen, that's painful. And who likes compression? I've never heard a patient say, oh, wow, what did I do first thing this morning when I got up? I put my stocking on. No, that's not how it works. So all these complicating factors that are really tough for us to initiate, well, maybe not so much to initiate, but to keep ongoing. When I say medical and social problems, I think I should have said medical and social complications there. What if the patient does have other issues going on, for example, uncontrolled diabetes, some other kind of autoimmune disease that is getting totally interrupted by the oncology aspect of all of this. And when I say social problems, again, I mean social complications. Okay, I'm not going to go see them, they're sick. And like Cynthia mentioned, the support is what gets you through this journey. So I've had several patients who are depressed. They don't sleep. They've turned to alcohol. They've turned to marijuana use. How does that play into their chemotherapy, people? It has a direct effect. So, and as we know, chemotherapy drugs are good for us in fighting our cancer, but they also have a deficit on our wound healing situation. And steroids. How does that help my wounds? It doesn't. So Cynthia and I have probably seen a lot of patients, and you too, where the family is not dialed in to help. It's too overwhelming for them. I recently had a patient who told me she got to go to a local wound care facility. She was immediately told to leave because she smelled. They had nothing that they could help her with. So that's where they get discriminated against. And last but not least, I got cancer, I had surgery, now I'm radiated, and now I got skin damage. So it's one complication after another. Those are our patients. So do we have a good plan or do we have a bad plan? As you can see on your right, your left, this is what we used to tell everybody. But as this symposium is all about, what have we learned over the last 15 years? We got innovation, we got education, and we got interventions that can help us move past from that side of the board to this side of the board. And that's what we're trying to touch base on. How can we control pain? How can we increase sleep, nutritional intake? How many of you are in cahoots with a dietitian in your area? Very much needed for wound healing, right? When I have pain, I don't move. I got physical limitations, and that makes me dependent on some other family member. I'm taking care of a lady that you'll see her picture in a minute. She's sick with cancer. Her husband's got melanoma. So they're having to rely on a lot of family. So it's a burden to them. And as Cynthia mentioned, getting a parking pass, transportation, being sick ain't cheap. I used to have a social life. My friends used to come around. Now they don't want anything to do with me. So I am powerless. So this is where these people are. So what I want to impress upon you guys is when you're taking care of these patients, know what your unit protocols are. If you don't have a unit protocol and you don't have any supplies, perhaps that is a great VIP for your plan. Let's see if we can get the minimal dressings in, the minimal things to just put something on this patient until the wound care nurse can get there. Because perhaps the wound care nurse can't see them at that visit, but maybe I can put a Band-Aid on them or bridge them to the next time they get back to the clinic, or they can see the wound care nurse. So take photos. That helps us tremendously. Put the photos on the chart, and then maybe you can call the wound care nurse and say, hey, let's have a discussion about what I saw. What can I do? 3 years later, when you get deposed to go to court because the family says you didn't properly take care of this patient, you can go back to your notes and go, yes, I did. I spoke to my wound care nurse, and as Cynthia mentioned, the mantra of a wound care nurse is moist wound healing. Not dry like a desert or wet like a swamp, but somewhere right in the middle. That's what I want you to remember. And how many times have I repeated the same discharge instructions over and over again? They don't remember it because they only hear about a third of what you say. Write it down. Arrange home help services if possible, and that's where your social worker or case manager can get involved. Ordering DME supplies. If your unit doesn't know how to order DME supplies, get in contact with us. We will show you how to. And insurance will take care of a lot of these products. Because the patient can say, yeah, I ordered something on the internet, and it wasn't what they needed. So what I'm going to quickly talk to you guys today about is radiation dermatitis and malignant fungating wounds or malignant eroding wounds. And you can see my statistics and my information right there. Do we heal malignant fungating wounds? No, but we can manage them from a palliative perspective. Is it okay to tell a patient who's going through acute radiation dermatitis, you're just going to have to ride this out? No. We've got other things we can do. And any patient going through radiation therapy is at risk for some kind of skin issues. So this first lady was a lady who had radiation, and I got called down to the rad clinic saying, hey, this lady's just losing all of her skin. And as you can see in the far left picture, she was using 3 different types of ointments on her skin because she thought more is better. She was what I call degloving. Look up underneath her axilla. The skin is going. I thought she was just going to lose all of her skin. And you can see down in her inframammary fold where it's glistening, there was just a lot of drainage everywhere. So I said, well, you can only use one product, not 3. So she backed off to what I suggested, and that's picture number 2, the middle picture. And then the next time she came in, you can even see where she lost her pigmentation from all the changes, but this looks so much better. And this is a good question to ask. Do we detect skin issues with darker tone people? Maybe we don't as quickly initially as we can, but try to be a little bit more like step back or have a light with your phone maybe and say, hey, I think I see some changes here. Let's see if we can address this prophylactically. I don't want this to go derail on me. But in this situation, the patient literally thought, well, more is better, right? This is a sweet lady who had a total left mastectomy. And all she wanted to do was to get to Italy to see her son, her nephew actually get married, her sister's son. But unfortunately, when she finished her radiation, she got back to living life, she started wearing the clothes that a women wear, bra. The next thing you know, she had breakdown right where the bra met the chest line. And she said, I didn't do anything, and it wasn't even really tight. But this is what she ended up with. So any field that has been irradiated, it's a commitment from a wound care nurse to try to tackle. And if the patient is engaged and committed, so are we. And I want to say, all in all, I saw this patient for about 3.5 months. She did get to go to Italy. She had a wonderful time. But she wore a bra when she was in Italy. And she came back, and it opened up again. The last time I saw her, this is what was left. So I think radiation is the gift that keeps on giving. Would you agree? My skin is healed. 5 years later now, my skin is open. But I don't have cancer anymore. So it's a balance. It's definitely a trade-off. So I think the take-home message with this lady is, will she always have to wear a dressing? Maybe. But if that's all it takes to keep her skin happy, she's all in. She's dialed in. And maybe you saw this poster that I presented last year here at the Symposium of this gentleman who had a Merkel cell carcinoma excised from the dorsal aspect of his left hand. We saw him, got him all healed up with the split-thickness skin graft. He immediately went to radiation. About a week after he finished radiation, he called me and he said, I think I got a problem. I go, what is it? I don't know if my clicker works here. Well, my hand is swollen, and I got all this gunk on there. Well, what's the gunk? Silver sulfidine. It was too painful for him to take it off, so he just put more on. And he wasn't using the right kind of cover dressing, and most of the time it went exposed. Okay, so I whittled off all of the silver sulfidine and used another product that was literally just a spray product and put him in a compression garment, and within a month's time, this is where we were. So the take-home message here is we have alternatives. If your doctor is hell-bent on using silver sulfidine or mometasone, the one take-home message I want you to ask that doctor is, does wet plus wet equal wetter? If that doctor's a smart doctor, that doctor's going to go, well, I guess kind of so, yeah. So that, again, is the mantra for wound healing. I don't want my wound to be soggy wet. I want to move the needle more in the middle. And how do I do that? Well, it can't be lathering up with silver sulfidine. It may have been a great product 10 years ago, but even your burn units don't use silver sulfidine anymore. So let's fast forward on. This is a lady that we took care of. She had Merkel cell cancer on her left cheek. We got her healed up. She went to radiation. She came back, and the middle picture is a poor rendition of what this really looked like. Edematous. Parts of it were wet. Parts of it were dry, and this erythema went all the way up her face to her temple, behind her ear. Her eye was so swollen. I called the radiologist, and I said, I think we have a real issue here. I think she's going to lose her eyesight. Now, what do you think I should have done to that wound? Or her face? Do you think I should have put silvasulfidine on it? No. So, again, the same product that I put on the gentleman's hand, I put it on her face, and 3 days later, the first picture is the initial presentation. 3 days later is the center presentation, and a month out is the last presentation. In other words, we have things that work. So here's our past management. I've talked to rat doctors, and they go, I know what I like, and if I run into a problem, I'll call you. Okay, that's fair enough. But is it fair to the patient? Talk to your rat doctors and say, hey, I think we can do something a little bit better. This isn't going the way we really would like for it to go. Oftentimes, when I see patients and they're in acute radiation dermatitis, it's due to the maceration. The wound is just spitting out all this drainage. Well, what happens when that occurs? You're at higher risk for infection, right? Okay, I got a patient who's got this issue. Now I'm going to give them another issue because I'm not treating it appropriately. So that's what I mean here. They get caught in this cycle, and it's painful, and it becomes even more painful. So that's where I say our current clinical approach, and Cynthia has had excellent outcomes with this as well, is that we're getting rid of all of those ointments, and we're using a spray that every wound care nurse has in her pocket. And it's the terpolymer. I can't use brand names, but if you want to know what it is, come up and ask me later. Simple cover dressing, and on that lady's face, you can imagine how difficult it was for me to put a dressing on her face, and it was only needed to be covered over the wet areas. But if you have somebody who's experiencing edema, find some kind of way to manage that edema. That inflammation will come along a lot quicker if you can manage the edema, just like on Cynthia's patients with her case study. But the most important thing, even though silvasulfidine is very expensive, it has to be applied. I was always told it had about a 10-hour activation time. So that meant if you were an inpatient nurse, you had to apply it BID. I can tell you right now, you won't come to me twice a day with something you have to clean off, put more on. It's too painful. So we found another approach. That's the take-home message here. Most recently, this lady is a patient who had a left total mastectomy in 2009. She then went to radiation in 2009. Fast forward to June of this year, she had a lump, a nodule along the well-healed incision line. She went to an outside hospital. They excised the nodule. The doctor said, this will heal up in no time. Don't worry about it. The center picture is what she came to us with. All right, that was in June. It's August. The daughter says this isn't going well. Now, you see all the redness? That's not infection. That's due to the inflammation process and the radiation changes of her skin. She did not have an infection. But see all the yellow slough in the center picture? That's just slough. So not only do I have a wound, but I have a different wound. I have a complicated wound that's complicated by irradiation. What am I going to do now? Uh-oh. Well, if I've got a wound that's draining a lot, the peri-wound skin is going to take a hit, right? Then a fungal component is going to set up, and that's what's going on here. But our goal is to get as much of that yellow slough out of that wound as possible, and fast forward to the picture closest to me where you see a lot more viable tissue setting up in that wound. So we've put it in a good place to start healing. This is going to take a long time. She's diabetic, not well controlled, so I got a couple things working against us. But along with my colleagues down at DeKalb, we're making headway with this wound. And her left arm is swollen, and she hasn't been wearing her sleeve. Last but not least, I see some of my St. Joe's friends. We see these fungating breast tumors quite often, more often than we'd like. This is the only picture that I don't have a patient. I took this one out of one of the articles that I reference, but this probably looks better than the one that Luz and I have been so involved with. These patients, you might ask, well, why in the heck would a patient let something like this go? Because they think they can manage it themselves. I got this. This is one more thing I don't need in my complicated equation. My family doesn't need to know about this. I can handle it. But then it gets overwhelming. Then when it starts draining, the malodor comes along. They finally come to us in this condition. How many of you have ever come across this? So have you ever wondered what causes the odor, the malodor? It's the drainage. It's the anaerobic bacteria. So one of the things that we like to do, and wound care nurses have done this for a long time, and it really, really works with the odor, is crushed up metrodiazonol. It's very inexpensive. And I tell people all the time, you either get the capsules, we'll prescribe you either the capsules or the tablet, crush it up, put it on a zero form gauze, any kind of Vaseline gauze. Excuse me, I shouldn't have said zero form, that's a brand. But petrolatum, put it on, and it will tame the beast. It's the best way for me to explain that. But imagine these people. How many people have you seen like this, and their families don't? The family that's with them doesn't even want to look at it. Oh, I can't look at that. So it becomes very overwhelming for the patient. So we have to approach this from a palliative perspective. So this is another absolutely charming lady who's got this more eroding tumor on her mid-chest. What you see on the far picture is an infected port site, but we won't even talk about that. But her biggest issue was bleeding. Every time she took her dressing off, she bled. And that was where all her anxiety was from. She said, I'm bleeding to death. So fast forward, we put the metrodiazonol on, and yesterday I just got a newer picture, and I said, the bear has gone to sleep. I can't tell you how happy she is. She feels like she's got more time to live. And she's the one whose husband is really sick. Last but not least, this is a patient of Cynthia's. I think the take-home message here is I want you to know that these fungating wounds don't just happen on the breast. They happen on the face, the arm, the legs. This is the sacrum at the coccyx. And luckily, the doctors were able to excise it and close it. And I want to go back quickly to this. I know I'm running out of time, but you might say, well, what about these wounds? Can they be excised? Yes, we have a breast surgeon that we work closely with who has done palliative excisions. There's a lot of hospitals and doctors out there that don't believe you should do this. It has to meet certain criteria, but it can be done if there's enough tissue to close the wound. You want to give the patient another wound. So talk to your doctors. Hey, would you consider this? Because this gives the patient a lot more quality of life, a huge amount of quality of life. So there's the schematic about the fungating or eroding ulcers. What can you do to tame that malodor? There it is with the petrolatum. Got any bleeding? You know what to do with the silver nitrate. And that's it. Any questions? If you feel free to come up onto the microphone. The physician I was talking about, the surgeon, is under the surgical oncology umbrella. She might get plastic reconstruction in with her. She is a proponent to do this. She has met some speed bumps with administration not wanting her to really do these, which the last research I read says, wow, that is not what we should do for our patients in a palliative setting. A lot of times when you can excise these tumors, you can at least give the patient another year and a half of high quality of life, which is our goal, right? So, but that has to meet certain criteria. Has the area been irradiated? Is there enough tissue to close? So there's a little bit of hoops you have to jump through.
What happens to the skin when it's been irradiated, the long-term effects, short-term effects?
Interesting that you should ask that. When our skin is irradiated, there's a metamorphosis that occurs. There's vasodilation, there's edema, the cells replicate differently. And I'm not a radiation oncology nurse, so I don't know the nuances. Perhaps there's someone in here that can kind of give us that a little bit more information. But I know if I've got any kind of field that's been irradiated, my chances of healing that wound are so complicated. Physiology, the aspects of it, the digging deep aspects of it, I cannot tell you how. I know that I have so many stages, 4 good stages of healing, and I think it really knocks out the proliferation stage of healing, where my body can't make more collagen. My body gets stuck in this inflammatory process because I'm not making cytokines, fibroblasts. Inflammation stage comes right before proliferation, and it gets stuck in there, and the cells just can't. It's just a tougher situation. I probably didn't answer your question as good as it could have been, but in my little pea brain, yeah. Yes, ma'am.
I work at the Emory Midtown location.
I can't.
I just want to provide some insight. So when the patients complete their radiation treatments, it's very important that you, at that final treatment, discuss with them what they should do and what they should expect. The radiation is cumulative, so those skin changes can occur from the radiation 6 weeks and beyond. So what we do is we schedule a 1 week to 2 week skin check, so that we can bring them in to check the skin. It's very emotional and it's painful. So that's something that, as a rad nurse, if that's not your practice, that should be something that you should be aware of. So you can be that advocate and that support for that patient, because it's very emotional and painful. Also, I would like you and I to talk afterwards so I can see about that project, because I really would like for myself and my colleagues to have a better, more confidence and knowledge on what we can do in that basic. We do facility, we have dressing, but we still don't feel as confident as we would like to in those, treat these things and help them.
I'm at St. Joe's, and that's where I come in contact with the Radonc group, and I have to say they do a really good job there. And all of these patients that I presented to you today are in the post-radiation period. They finished their radiation. They think they're out of the woods. They're going to go live life, and then all of a sudden they get tripped up with skin issues. So I totally agree with you. It's the aftercare. It's protecting that skin. It's delicate. It's accumulative, just like she said. So you have to protect that skin.
You mentioned, for those of us who, honestly, I have no wound care experience at all in my career. And you mentioned putting a simple moist dressing on our patients before, like while they're waiting to see you. Can you kind of give more information about like what precautions or what we should do if we're trying to dress something while someone's waiting to see wound care?
Okay, if I understand your question correctly, it's like, what can I put on this until the wound care nurse gets there? And so if you have a wound that's draining a lot, the go-to has got to be an ABD. And Cynthia, please step in. I find that if the more 4x4s I put on something, the wetter the wound is going to stay, because it mops up drainage, but it doesn't wick the drainage away from my skin. If I use an ABD, I kind of think of an ABD like a Kotex pad, right? And I tell my patients all the time, especially men, I need you to go to the store and buy Kotex pads. And the men will go, I'm not buying a Kotex. Well, they're cheap. You can cut them up, and then you're not breaking the bank. they get it then. And I even had a lady recently, Suzie, our lady, she had this fungating tumor that was so huge, she used an infant diaper on it because the shape of the diaper cupped right onto it, and they're relatively inexpensive compared to individually wrapped sterile dressings. It's just, and patients get stumbled on this. Well, I need a sterile dressing. No, you don't. This isn't a sterile area. If I sterilize this area, I'd kill it. Kill your good skin. And that's a big deal when you have a wound that's draining a lot. What do you have to do? Not only mop up the drainage, but you got to protect the peri-wound, which was what Cynthia mentioned earlier about with her zinc ointment. Because that patient's going to eventually say, my skin out here itches. And now they've got it infected because they've had gunk underneath their fingernails, they scratched, next thing you know, they got a staph infection. So that would be my first take home. A lot of times we'll use the panties that are in the pyxis, where you cut the crotch out, to put it around their chest, their head, their neck, whatever. Got to stabilize it some way. And I don't want to put tape on irradiated skin. That's only. And the lady with the chest wound, that's what they would do. And they were actually buying the big Band-Aids like that. In my opinion, a Band-Aid is the worst thing out there to try to mop up anything that's spitting out a lot of drainage. It just doesn't work. So, did that answer your question?
Yeah. And is it something like, as far as ointment to protect the skin, because we or the patients don't necessarily have access to zinc and things? Is that just like a petroleum-based something?
You can buy petroleum infused gauze at CVS or Walgreens. You can make your own. Why are we using petrolatum gauze on the fungating in particular? Because how many of you have used those no-stick dressings? They stick, don't they? And then that's anxiety for the patient because they pulled it off and now it's bleeding like crazy. Now they're stressed out about that. So when you use a petrolatum-based dressing, even if you smear it on the ABD and put it on, then when you take it off, it's atraumatic. Or I tell them, get in the shower and take it off. It's sticking. Or get some wound cleanser spray, saturate it, get it off. You know, I was at a conference in Cleveland in June, and a gentleman got up and said he was with hospice, and he says, you nurses like to put these fancy dressings on there, but the patient can't afford them. So we have to think back about something that's more doable, like the diapers or the Kotex pads. And I go, I get it. So there's a lot of silicone-bordered dressings out there that we absolutely love. Patients love them, especially on the breast. They're rather expensive. So.
Are we still using Telfa on some of the wounds, Telfa pads?
I don't like Telfas. I think they're not absorptive at all. And those are the ones that stick, I think. Well, those are the ones that stick.
How do you feel about honey?
Honey?
Meta honey on a fungating tumor? Cynthia, you might use meta honey more than me.
What was it about them? What? How do you feel about using honey? We will recommend honey. It just depends on the wound. Okay, so I usually use it on like superficial open wounds that may have a little bit of slap that I want debrided. So, and also it's antimicrobial. Okay.
So I was always taught that you use meta honey when you're trying to debride non-viable tissue in a wound. So has your wound got non-viable tissue in it? That would be when you would like, okay, let me get some meta honey.
Okay. A GYN patient calls in. They got radiation. They have, based on the pictures, it looks like moist desquamation to the groin area. What do I tell them?
Oh, have I got a journal article to show you? That's that spray that I was talking about. There's a company out there that makes a product specifically for moisture-associated skin damage in these areas, that when you get up and you walk, the shearing because one body part touches the other body part, and that's where the skin breaks down. But add in the moisture component, and it makes it even worse. So I'll definitely give you the name of that. Please see me. I thought it was a very interesting article just on that area that had been irradiated.
Okay. Are there any more questions?
Okay.
Good morning, everyone. My name is Elena. I'm actually the nurse manager in Head and Neck. And my question is for Cynthia. What are, I guess, 3 tips that you would give our head and neck patients as far as wound care that they can do at home?
Mainly, it depends on the wound, always. But we always want to keep them nice and moist. So, and a couple of weeks ago, Katie and I, we actually had a presentation to give to the ENT residents. So instead of recommending leaving things open to air, we always recommend keeping the wound covered, okay? Keeping it moist, helping it heal. And also, again, the edema, if they have a lot of swelling in their lower legs, compression. They can go to Walmart and buy compression socks, and they're not that expensive, and also it is extremely helpful for them.
But you're talking specifically about head and neck?
Yeah. But they also have, they have flaps.
Yeah, they got edema.
The head and neck, I find that there's a lot of wetness. So just trying to control the wetness by using ABD, something inexpensive to cover, and also to protect the treatment skin. Gotcha. It's really important, either with a skin trap or a barrier cream. And people can buy zinc barrier creams.
Okay. All right. Thank you.
I think it's important to ask people this question when they say, well, why can't I just let it be open to air and let it dry out? Because that's what my mama told me I needed to do, and that's what my grandmama told me to do. I hear that a lot. How much money does every woman in this room spend on moisturizers in a year? So why do I really want anything on my body to dry out? I'm made of what, 75, 80% water? Why do I really want anything to dry out? Unless I'm a diabetic, that's different. That's a different arena. But there's that mantra of a wound care nurse. Not dry like a desert, not wet like a swamp, but somewhere right in the middle. Moist wound healing. So again, if you're up on the floor or you're in your clinic and you're like, I just got to put something on this, think in those terms. I'm not going to put something wet on something wet. I'll make it wetter. I've got to kind of move the needle somewhere in the middle. And something like an ABD will never do you wrong. Cut it up. Do whatever you need to do. Thank you, guys.
Thank you. Thanks, everyone.